Welcome to Roadmap to Residency, Evidence-Based Applications. In this video, we will be talking about hypersensitivity reactions. First of all, we will dive deep into the theory part, and then we will solve some questions for the recall purposes. So I'm Aviras. Welcome to our Club 250 Matchmaker sessions. So hypersensitivity. So whenever there is first contact with the antigen, which is called a sensitization, there is generation of immune response by the antibodies and memory cells. And whenever there is second contact, there is hypersensitivity. So the symptoms from overreaction of the immune system. So there are four patterns of underlying immune response, type 1, 2, 3, and 4. We will be learning about all these sort of hypersensitivity reactions. So type 1 is the immediate reaction to an antigen, which occurs within minutes. It can be due to some antigens like pollen, pig dander, or peanuts through the preformed IgE antibodies, okay, which is by the primary exposure. The antibodies bound to mast cells, and antigen binds and cross-links IgE. Then there is mast cell degranulation, and the susceptible individuals make IgE to antigens, and majority of people make IgG. But IgG does not trigger hypersensitivity response. So the susceptible individuals who have these allergy sort of things, and they form a great amount of IgE molecules. So the IgE results from the B cell class switching, driven by the Th2 cells, which is the immune response. Interleukin-4 is a key cytokine for the IgE production. There is no complement, and the IgE does not activate complement. So the type 1 symptom consists of skin. So in the skin, there may be urticaria or hives. In respiratory tract, there may be wheezing, rhinitis, and in eyes, it can be conjunctivitis, or in the GI tract, it can cause diarrhea. So anaphylaxis is a systemic type 1 hypersensitivity reaction, which consists of the symptoms like itching, diffuse hives and erythema, respiratory distress from bronchoconstriction, hoarseness leading to laryngeal swelling and edema, vomiting, cramps, diarrhea, shock, and death. And the treatment of anaphylaxis is epinephrine. So the type 1 example consists of asthma, penicillin drug allergy, seasonal allergy, allergic rhinitis, allergic conjunctivitis, peanut allergy, that is children, and shellfish or food allergy. So the type 1 symptoms, so early symptoms occur within minutes. There is degranulation, release of preformed mediators, histamine synthesis or release of leukotrienes, prostaglandins, edema, redness, and itching. Late symptoms consist of nearly 6 hours later, the synthesis release of cytokines, influx of inflammatory cells, and induration. So the type 1 mediators are histamine, which causes vasodilation and warmth, increased permeability venules, which can lead to swelling, smooth muscle contraction, which can lead to bronchospasm, leukotrienes, prostaglandins, and thromboxanes, which can be derived from arachidonic acid. So icosanoids are one of the mediators of the type 1 hypersensitivity. So the PZE2, they causes redness due to vasodilation, edema due to permeability, fever because of the action of hypothalamus, and pain. PZD2 causes bronchoconstriction, eosinophil infiltration. The leukotriene C4 and D4 causes vasoconstriction and bronchoconstriction, and leukotriene B4 causes eosinophil chemotaxis. So talking about now type 2 hypersensitivity reactions, the antibodies IgG and IgM directed against the tissue antigens. They bind to the normal structures, and there are three mechanisms of tissue or cell damage. It can be due to phagocytosis, complement-mediated lysis, or antibody-dependent cytotoxicity. The phagocytosis occurs through the Fc receptors or C3b receptors on phagocytes. The complement-mediated lysis occurs through IgM or IgG, which is along the classical complement cascade, and there is formation of MAC, which can lead to cell death. And ADCC, which is also called as the antibody-dependent cell-mediated cytotoxicity, there is a role of natural killer cells which bind to the Fc portion of IgG. So the type 2 examples are rheumatic fever, when the strep antibodies cross-react with cardiac myocytes, exposure to wrong blood type, which can cause RBC lysis or erythematosus fetalis, autoimmune hemolytic anemia due to methyl dopa and penicillin, and mycoplasma pneumonia, pemphigus vulgaris due to antibodies against desmosomes and epidermis, Goodpasture syndrome due to nephritic syndrome and pulmonary hemorrhage, and type 4 collagen antibodies, and myasthenia gravis due to antibodies against the anticholine receptors. Now, talking about type 3 hypersensitivity reaction. So, it is an antigen antibody IgG complexes form that is it activates the complement, which can cause tissue or cell damage. So, it can be generalized, for example, serum sickness, or it can be localized type 3, example, Arthur's reaction. So, the generalized type 3 or the serum sickness. So, whenever there is immune complements in the plasma, it can cause systemic disease. It is usually via the IgG or IgM complement activators. It deposits in various tissues like skin, kidneys, joints. It triggers the immune response, complement activation, and activation of macrophages and neutrophils. So the generalized type 3 is via the serum sickness, which is via the urticaria, palpable purpura, low serum complement levels, elevated sedimentation rate, diffuse lymphadenopathy, and acute glomerulonephritis. And in case of classic serum sickness, there is rabies or tetanus antitoxin. Rarely, penicillin can cause serum sickness when the drug acts as heparin, and some of the monoclonal antibodies drugs like rituximab and infliximab. Other type 3 diseases are post-strep glomerulonephritis, SLE, and polyarteritis nodosa. The localized type 3 hypersensitivity is called as the Arthur's reaction. So whenever there is local tissue reaction, usually in the skin, for example, if there is injection of an antigen or performed antibodies in the plasma or tissue, it forms the immune complexes, and there is the local immune complexes. It occurs 4 to 10 hours after injection, and in contrast with type 1 reactions that occur in minutes, there is complement activation, edema, and necrosis. And on immunofluorescence staining, you can see antibodies and complement in the basal walls. So it is reported with skin injections, for example, in case of tetanus, diphtheria, hepatitis B vaccines, insulin. There is swelling and redness at site hours after injection, and there is hypersensitivity pneumonitis, farmer's lung disease, and hypersensitivity reaction to environmental antigen. So the type 4, which is also called as the delayed type hypersensitivity reactions, is a cell-mediated reaction. There is no antibodies. That's why it is different from 1, 2, and 3. Here, the memory T cells initiate immune response. The classical example is PPD test. So whenever you inject a tuberculin protein into the skin, so the previously exposed person has memory T cells. And the CD4 T cells recognize the protein on APCs, and there is Th1 response. Interferon gamma activates macrophages, and interleukin 12 from macrophages stimulate the Th1 cell, which results in the redness and intubation 24 to 72 hours later. Immune response to many pathogens, example mycobacteria and fungi, is through the type, for example, type 4 hypersensitivity. Also, one of the major important reaction is contact dermatitis, that is poison ivy. The chemical or oils attached to skin cells involves the CD8 T cells that attack the skin cells. There is erythema itching 12 to 48 hours after exposure. Now let's go through some of the questions. So which of the following is the most likely mechanism responsible for this patient's symptoms? A 56-year-old woman comes to the emergency department with facial swelling and difficulty breathing. She woke up today with a feeling of fullness in her lips, and 2 hours later, her husband said that her lips looked puffy. There is no itching or skin rash. The patient has had no similar symptoms before, and she has a history of gastroesophageal reflux disease and takes lansoprazole daily. She also began taking lisinopril 2 months ago for hypertension. The patient's blood pressure is on a 35/175 millimeter of mercury, and on examination, there is a moderate swelling of her lips and tongue. Mild audible stridor without wheezing is present. Which of the following is the most likely mechanism responsible for this patient's symptoms? Bradykinin accumulation, hereditary C1 esterase inhibitor deficiency, IgE-dependent mast cell degranulation, increased renin secretion, and non-immune mediated mast cell degranulation. So the causes of angioedema. So by mast cell activation, it causes type 1 hypersensitivity reactions, and also it can lead to associated pruritus and urticaria. Whereas in case of excess bradykinin, in case of ACE inhibitors and C1 inhibitor deficiency, where there is no pruritus or urticaria. So we can see the picture of angioedema here, where there is the asymmetrical upper lip swelling. So the angioedema is a rare and potentially serious adverse effect of ACE inhibitor therapy. Symptoms typically appear within days of initiation, but can also occur after weeks to years of therapy. All the angioedema can affect any tissue. It is most commonly involves the tongue, lips, or eyelids. Laryngeal edema and difficulty breathing may also occur. ACE inhibitor-induced angioedema is due to bradykinin accumulation. Normally, ACE is responsible for bradykinin breakdown. ACE inhibitors prevent bradykinin degradation, leading to decreased level. Bradykinin is a potent vasodilator that ultimately increases vascular permeability, causing significant angioedema. ACE inhibitors should be discontinued in patients who develop angioedema. Now, which of the following substances is most likely directly responsible for the skin findings observed in this patient? A 5-year-old child is brought to the emergency department by his parents for right arm pain. The patient reports that he was playing hide and seek outside and felt a sharp pain on his arm while hiding in some thick bushes. His parents suspect that something has stung him. Physical examination shows an edematous and erythematosus plaque with mild central pallor. A residual stringer located central to the lesion is readily extracted. The physical examination is otherwise not significant. So C3b, interleukin-2, histamine, lysozyme, or TNF-alpha. So this child is experiencing a localized allergic reaction to an insect sting. The cutaneous findings are consistent with a wheel and flare reaction and erythematous papular plaque, often with central pallor and peripheral erythema. During initial allergen exposure, a patient predisposed to an allergic response will undergo antibody class switching from IgM to IgE antibodies specific for the allergen. The IgE produced by B lymphocytes and plasma cells then binds to the high affinity IgE Fc receptors on basophils and mast cells. And when there is re-exposure to the allergen, it results in cross-linking of bound IgE antibodies with subsequent degranulation and release of inflammatory mediators. The localized vasodilation and increased vascular permeability result in the characteristic wheel and flare lesions. Now, this is wheel and flare. So again, we have this one more question here. So which of the following mechanisms is most likely responsible for resolution of these drug reactions? A 36-year-old woman with fistulizing perianal Crohn's disease comes to the office for a follow-up appointment. 8 weeks ago, the patient began receiving intermittent injection of infliximab, a chimeric human mouse monoclonal antibody targeted against tumor necrosis factor alpha. She reports improvement in fistula discharge and discomfort, but has experienced fever, diffuse joint pain, and itchy rash up to 7 days after each of the recent treatments. The symptoms spontaneously resolve after 2 to 3 days. The patient has no other medical conditions and has no history of drug allergies. A delayed drug reaction due to formation of antibodies against foreign drug component is suspected. Which of the following mechanism is most likely responsible for resolution of these drug reactions? Here are your options. So there is answer is A, which is the activation of the mononuclear phagocyte system. Now this is somewhat about the complement pathways. There's classical, alternative, and lectin pathway, which again through all acts to form the C3 convertase. Whenever there's from the formation of C3, it gets dissociated into C3A, which is anaphylaxis, and C3P, which is opsonin. Opsonin acts on C5. C5b acts on the membrane attack complex, the MAC molecule. So the chimeric monoclonal antibodies such as infliximab contain amino acid sequences from human and non-human sources. Now, these proteins are processed by antigen-presenting cells, displayed on class 2 major histocompatibility complexes, and the non-human components are recognized as foreign by patrolling CD4 cells. The CD4 cells then stimulate the activated B cells to undergo somatic hypermutation and class switching, which generates the plasma cells that secrete high-affinity IgG antibodies against foreign components of the drug. Now, this is all about the classical complement activation and all, the direct removal and all. Thank you for watching. Keep studying.